Hello.
Hi.
Um, Thank you to Anna and everybody for inviting me. Can you hear me all right? I've been told I have a booming voice, so if I deafen you, tell me to shut up a little bit. My name's Ciara. Very nice to meet you all. I've worked at Milton Keynes Hospital for nearly 30 years now. I started in 1996, and I remember within about 3 weeks ringing my mum in Ireland, crying like a baby on the phone at 21, going, I don't like it, I don't like the job. And in typical mum style, she said, just stay with it, it'll be grand, it'll all work out. So I just put my head down and got on with it. And about, I don't know, 3, 4 months after I started, my manager said to me, oh, we've a little spot coming up for some hours in the community. Do you fancy doing that? And this was in the days before you had to interview for stuff. I'm that old. So I said, yeah. I said, I'll give it a go. So off I went out, and funnily enough, the very, very first person I ever saw in the community was a lady with Huntington's disease. And I remember coming out of her house and getting back into my car and just thinking, oh, this is just a little piece of me. And I think I just found my niche, and I've worked in neurological conditions ever since. So, am I going the right way? I am. So, just a little recap. Obviously, I've stuck to the conditions, obviously, on the agenda for today. Although I see lots of other neurological conditions as well. But I've stuck with these four. And although they're obviously very different conditions from a nutritional point of view, there's lots of similarities between them. And I thought I would run through the similarities and then go through the slight differences for them. So dysphagia, posh word for swallowing problems. Swallowing problems are really common in all four of those conditions. And the dysphagia then leads to extended meal times. And Dr. Butterworth touched on that with regards to eating is pleasurable when it takes you 10, 15, 20 minutes, 10 minutes if you're me probably, to eat your breakfast or your lunch or your dinner. Frequently, when I go out, I often ask people how long it takes them to finish their meals, and it goes from 20 minutes to 30 minutes to 3/4 of an hour. Sometimes, kind of further into the disease progression, it can be an hour and a half, literally, to eat a sandwich. And from that point of view, I kind of wonder how pleasurable meal times are at that point. And keeping in mind, not only are they now having extended meal times, but they have quite often weight loss. So I'm telling them to eat more. So they're looking at 3 meals a day. They're often looking at 3 snacks a day. And quite commonly, you have people kind of saying, oh God, every time the wife rounds the corner into the sitting room, she's got a plate of something for me. She never comes near me anymore unless she's bringing a plate of food. And people often complain, I literally do nothing all day other than try and get enough food into me. So it's a real problem. Weight loss is a real, and again, it's all linked in with all of these things. When you have swallowing difficulties, it's taken longer to eat your meals. Eating is just not as pleasurable, so people often just go, "Oh, I don't really know what the reason is. I just don't have any appetite when I ask them kind of what difficulties they've been facing. And all of those things kind of contribute into weight loss, and quite significant weight. It's not just sometimes a few pounds. Sometimes people have lost stones by the time they get referred to me. Thankfully, we've really good MDT, and it's a rare occasion nowadays that people have lost stones by the time they get to me, and all the rest of the team know to refer at kind of quite as soon as that downward trend has started. It's a good idea to refer. Quite often difficulty gripping cutlery, and therefore feeding themselves or even getting your food from the plate to your mouth. I mean, I can only imagine the frustration in kind of, concentrating on getting the food onto the knife or fork or spoon, and literally you've lost 3/4 of it by the time it actually gets to your mouth, and you have to start all over again. And again, this again contributes to the extended meal times. So yeah, sometimes kind of either wild or small movements, sometimes kind of stiffness, sometimes just not being able, actually they can pick the food up on the spoon, but then they can't turn it actually to get it into their own mouth. So lots of difficulties. Also, the swallow tires, so it's not just swallowing like a functional swallowing difficulty where things can go down the wrong way. It can also be that the swallow tires, and therefore the swallowing problems are actually worse towards the end of a meal than they are at the beginning of a meal. Or quite often you'll find that the food intake is worse for the last meal of the day, so your tea time, your supper, whatever you decide to call it. So breakfast is really good, lunch is fairly good. By the time evening time comes, the swallow has tired, sometimes they themselves have tired, and food intake drops. Chest infections and aspiration, again, you kind of regularly see that as a sign, really, in all of these conditions, and quite often as well, difficult saliva management. So it can be really, really thin saliva that's just, and you've probably all seen that, that's just dribbling out all the time. That can be quite distressing for people. I have people, say, for example, who only stand up and eat over a sink because of the amount of saliva that's produced, obviously, and that gets worse than when they eat. It can be the other end of things, and it can be really thick saliva. I've had people report to me that they literally have to put their hand in and scoop it out. It's that thick. They can, and all of those things obviously affect appetite. And then to go through kind of the differences, really. So for motor neurone disease, a poor lip seal, so not necessarily being able to seal your lips shut, and you need to do that to keep fluid in your mouth after you've taken it from your cup. So sometimes people obviously can get it in and then half of it dribbles back out again before they get a chance to swallow it, because their swallowing can be delayed and a little bit slow sometimes. When I go out and see people with motor neuron disease, they often do look at me and think, what kind of a dietitian are you? Because everybody, just the name dietitian, everybody thinks you're going to come out and go, right, eat lots more fruit and vegetables. If you're overweight, get your weight down, etc., etc. And when I walk in, and if they have, so a normal BMI, as I'm sure you all know, is 20 to 25. If lots of people have BMIs of 28 and 29 and 30, and I'll say to them, I don't want you to lose not even a pound. And they do kind of look at me as if, she qualified at all? Does she know what she's talking about? Basically, lots of people that work in the area know that actually being overweight is a protective factor for motor neuron disease. And there's big research projects going in various places around the country at the moment to actually get people, even say with a BMI of 24 or 25, getting them to actively gain weight to a BMI of 30 and seeing what happens to their progression as a result. I think most of the MDT know, but it's just trying to get that proof, really, that's beneficial. So normally we aim for weight gain unless the BMI is already over 30. Weight loss should be avoided at all costs. There's evidence that the disease progresses more quickly, and it's not that it affects the kind of bones of MND. It's the fact, as Dr. Butterworth touched on, it's you're kind of losing muscle with MND anyway. What we don't want to happen is we don't want to speed up that muscle loss, because when anyone loses weight, you tend to lose, if you lose it sensibly, so if you're overweight and you're losing 1 or 2 pounds a week, you tend to lose your fat bulk. That's one of the reasons why boring dietitians go, don't lose weight too quickly, because when you lose weight too quickly, you not only lose your fat bulk, but you start to lose your muscle bulk as well. And we don't want that, obviously, for this population of people. That can make them more debilitated in a quicker fashion. Early discussion for PEG is advised. And how early is early? It should be discussed when weight loss reaches 5%. So for most people, that's only in some cases a few pounds, really. As soon as you see that kind of downward trajectory, we should be discussing to have a peg placed. The peg can be placed, as it is with lots of people, early and then not used for however long. And some people haven't used it for months, sometimes, a year, 18 months, people, but it's there ready for when they need it. So early peg placement's advised. Constipation can be a massive thing. So the medications quite often that people take to manage saliva cause constipation anyway. So you're affected on that side. But also, obviously, the MND affects your muscle tone, and it affects your muscle tone everywhere, including the tone of your bowel muscles. So you have kind of two things causing constipation. So quite often that's an issue. And again, quite often really thick secretions. Um, there is anecdotal rather than hard fact evidence to support the use of pineapple juice. So pineapple juice contains something called bromelain, which is basically kind of like a digestive enzyme, and it actually helps to break down thick secretions. Lots of people try it. I would say, in my personal experience, because it's anecdotal, I would say 2/3 upwards find it beneficial. You'll probably find about a third of people go, "Oh, I did try it, and I don't really know whether it made any difference." So that's something, pineapple juice to try, but also very much increased fluids. One of the reasons, obviously, with dysphagia and losing fluids because of a poor lip seal is quite often, even with the best will and effort in the world, their actual amount of fluid that they're taking in drops, and that significantly increases the thickness of the secretions. So trying to maximize fluid intake is really important. Huntington's disease, I would say, it's interesting that Dr. Butterworth said it was one of the crappiest. It's probably, from a nutritional point of view, I would say head and shoulders above any of the other conditions with regard to the challenges from a nutrition point of view. And the main challenge is the top one. They can have a really, really high energy expenditure. So they can have a 14% higher resting energy expenditure. So that's when you're literally lying in a bed doing nothing for the day. 14% higher just with that diagnosis. And they're not 100% sure why the energy expenditure is so much higher. So there's various kind of theories at the moment that there's damage to the hypothalamus caused by the Huntington protein. There's a kind of theory about, do they have a thinner gut and therefore less food is digested? Or also issues with the mitochondria. The mitochondria is the kind of energy production center of every cell in your body. And there's a theory that our people with HD, their bodies just don't deal with calories the same as somebody without HD. Um, they can need upwards of 6,000 calories a day. So the average, I suppose, just to put it in perspective, the average government recommendation for a woman is around 1,800, for a man is about 2,500. So it's a massive, massive calorie intake. It doesn't happen with everybody with HD, and we don't particularly know why some people have a massive calorie requirement and others don't. I've seen it myself, where I remember one young lady that I had on my books. We had her on because I did a nutritional assessment, and you could work out exactly how much I had her on. Between diet and supplements, she was on 5,400 calories a day, and she was under 7 stone and still losing weight. And we never actually got her to stop losing weight before she died. So it can be really, really high. And even with placing a peg tube in some of these people, there is only so many hours in a day, and there's only so much feed that you can run in a 24-hour period, and sometimes you still can't get the calorie intake high enough. One of the things that we do notice as well as with the calorie intake is, for no Again, I can remember somebody I had in a care home, so he was on only peg feed, so we know exactly how many calories he's getting in every day, and day after day, it's perfectly the same. And for about 2 or 3 years, his weight was exactly the same on his peg feed, and without anything changing whatsoever, he rapidly started to lose weight. And that's the HD side of it. There was no other reason. Nothing had changed. We give him the same calories. He was still bedbound as he had been the weeks and months before. So there's not always a visible kind of reason for it, but it is the HD and that kind of energy production side of things. So as a result, you can see rapid, and when I say rapid, I mean really rapid weight loss, very, very quick. Um, Quite often, they can gulp at food and drink. So, if they already have swallowing problems and so on, that makes things even worse because they're kind of loading food or fluid into their mouth and actually having more difficulty than swallowing it. The motor symptoms. So again, I don't know how many of you have seen people with HD, but they can have obviously quite wild movements. So just physically being able, like we say, to get food from plate to mouth can be really, really difficult with HD. A regular food intake, so 3 meals and 3 snacks a day, has been shown to improve behaviour in HD. And people that I've gone out to see where they were just on their 3 meals a day, and I've advised having a kind of mid morning, mid afternoon, mid evening snack, quite often their families have reported, oh, he's a lot nicer to live with since we've been doing that. So regular food intake is really important and should be encouraged. And just a quick, I suppose, from a safety point of view, people with HD are not usually appropriate for if they have a peg placed. We wouldn't normally pump feed, and I'll go on and speak about tube feeding in a minute, but we wouldn't normally pump feed them unless they're bed bound, and that's down to the movements. So their movements can be kind of quite wild, and we don't want, they're physically obviously connected by a tube up to the feeding pump. We don't want them yanking the peg tube out or anything along those lines, so we wouldn't normally pump feed somebody with HD. With multiple systems atrophy, quite severe constipation is quite often, along with all the kind of mixed symptoms that I've already spoken about. Severe constipation, again, due to the medications that are used to manage the saliva, and also hypotension, so low blood pressure. And again, I'm going to have a separate slide on that, so I'll touch on that in a second. And progressive supranuclear palsy, again, Dr. Butterworth mentioned about the kind of looking up and down. How are you supposed to eat a meal if you can't look down to see it? And it's as simple as that. It's not any more difficult than that. You do get prism glasses, which some people use, obviously, which you can look straight forward, and with the fancy magic of mirrors, you can see down. So that's one of the big things, is obviously being able to look down and actually see your food. You need to be able to do that to be able to feed yourself. So, what's a good diet? A good diet, this is the bit where I also get people saying to me, God, does she know what she's talking about? Always what I say to people is, all the stuff when I walk around the supermarket with my trolley that I'm trying not to put into my trolley is all the stuff that you should be putting into yours. So it's basically the exact opposite of what the government will say to you about low salt, low fat, low sugar, low everything. It's the exact opposite. It's high everything for most of these people. So we want you to have a high protein, high calorie diet. We want people to avoid low calorie, low fat, low sugar foods and drinks. Obviously, beware the sugar side of things with somebody who's diabetic. We want 3 meals and 2 to 3 snacks a day. And then we want people automatically go down the supplement route about when people start to lose weight, they need nutritional supplements. I'll touch on nutritional supplements in a minute. food fortification is amazingly effective at either stopping somebody losing weight or getting weight on. Say, for example, the way I often describe it is when you've prepared a meal, or when people that you're seeing have prepared a meal, or you served a meal to them, what else could I squish into this meal that's going to bump up the calories? So you're talking really simple things. You're talking they have porridge in the morning, add some double cream into it. Double cream is hugely calorific. Add some double cream into it. When they're having their dinner, even if you look at the dinner and you think, oh, I don't really know what else I could add onto that, melt a knob of butter over the top of the dinner. Another 70, 80 calories it will add on for you. Add in, if they're having a yogurt for their pudding, add in a spoonful of double cream. If they're having milk puddings, rice pudding, whatever, semolina, add in some honey or some cream. If they're having mashed potato, where you might be adding that yourself at home, you might be doing skimmed milk, because I don't really want to put any butter in because that's too many calories. For them, you want proper full fat spreads, no low fat stuff, full fat spreads. You might say add in a little bit of double cream. You might say add in a little handful of grated cheese to bump up the calories. And suddenly your mashed potato is double the calories that it was. So please don't underestimate how effective those strategies can be. In order to start gaining, if someone's maintaining their weight, in order to start gaining weight, they need an additional 500 or 600 calories a day. And that sounds massive to most people. Most people, when I tell them that figure, they go, oh. When I say to them 3 or 4 knobs of butter, you're halfway there already. It doesn't seem such a big problem really to get it in. Plenty of fluid, again, from the secretions, the thick secretions point of view, and just general good hydration as well. Using high calorie fluids, quite often we get focused on food and we forget about using things like full sugar fizzy, again, be careful with diabetic, but full sugar fizzy drinks, and particularly milk based drinks. The fizzy drinks are just sugar, pure sugar, that's it. The milk based drinks, you will get some vitamins from them, you'll get lots of protein as well as the calories. So things like cups of coffee made up completely on milk, Horlicks, hot chocolate, cocoa, Ovaltine, anything like that. Milkshakes, just with some Nesquik milkshake powder into it, or some blended, I don't know, tinned strawberries into it with some ice cream. Make high calorie drinks, and not an awful lot of the nursing homes do that now. They make their own, what we call booster drinks, and they give them out kind of once or twice a day, which helps. And if they need a modified consistency diet, so if they've had a review by speech and language therapy and they say they need a pureed diet or whatever, please do always refer those people to a dietitian. We always ask that you do, because simply the extra fluids that you need to add in to meals to get them to the nice blended consistency dilutes down all the nutritional value. So generally, even though people on a pureed diet could be eating well, quite often you'll still find that they're losing weight. So nutritional supplements, just to touch on them, again, the vast majority of referrals I get, it mentions on the referral, need supplements, can you advise please? There is no miracle ingredient in any of these supplement drinks. There is nothing that has been added into them that magically has, or people often say, could you not just give me a pill to put some weight on? There is no added pill into these drinks that helps people to put weight on. They are simply a high calorie drink that have added protein and added vitamins and minerals to them. So don't get me wrong, they're really nutritional, they're really good. But if somebody said to me, which way would you rather gain weight? Would you rather do it with nice cheesy mashed potato and cream on your puddings, etc.? Or would you like to take a supplement drink? I know which one I'd prefer, most definitely. So they have their place, absolutely. What we would normally say is go the food first route. So if somebody is eating enough, do all the food fortification and the high calorie side of things. If you've done that and they're still losing weight, that's where the supplements come in. It's kind of like step 2, really. And just to point out, for most of the supplements, although just to confuse it, there are occasionally ones on the market where it is one a day, but the vast 98% of supplements, the therapeutic dose is two a day. If doctors quite often prescribe one a day, it's not going to be enough of a calorie increase to cause weight gain. It needs to be two bottles, two sachets, two whatever presentation it comes in. And then just to touch on the orthostatic hypotension, there are quite a few nutritional things that you can do to help with that. It won't it won't solve the problem 100%, but you kind of take one thing out of the equation. So it's an awful lot of the exact opposite. So if you've been diagnosed with high blood pressure, it's all the opposite stuff that we're asking people to do. So to avoid large meals and try and do little and often instead. To reduce carbohydrate intake, especially sugary foods. You know the way if you have your big Sunday dinner and you overeat, and then a half hour later you're thinking, oh God, I could do with a nap. That's exactly the same thing. So basically, blood rushes to your gut to try and digest all this food and takes it away from the rest of your body, and your blood pressure drops. So we wouldn't advise lots of sugary foods for somebody who is having big problems, particularly with things like multiple systems atrophy. They can have massive problems with low blood pressure. Increase salt intake. So again, people look at me going, and I'm saying, have more salty foods, get the salt cellar back out on the table, add some salt onto your meals and so on, the exact opposite to what they've been told all their lives. Increase fluid intake is really important to make sure there's good blood volume, and especially caffeine. So this is where it's the opposite to everything you're told, especially caffeine containing drinks. And what can be really useful is a lot of people first thing in the morning when they get out of bed have big problems with hypertension, is to try and have a glass of water while lying in bed and then not get up for a while. I don't know, my bladder could actually allow me to do that. As soon as I wake up, I'm like breaking my neck to get out to the loo. So I don't know if my bladder would allow, but if your bladder allows, that's what you should be doing. And also decrease in alcohol. And then just to go on and touch on to peg feeding, I know lots of you will have experience of peg feeding. If you don't, this is basically what a peg looks like. So it goes through the various kind of layers from the outside to the inside of the tummy. It's a reasonably, I know, and I totally understand why families get a bit overwhelmed initially, because having a tube hanging out of your tummy is by no means the norm, and I think smacks very much of, oh my God, intensive care type stuff. It's actually really low tech. This, the Freca tube, which is this blue and white tube that we tend to see 95% of the time in Milton Keynes, hasn't changed, not one jot, since before I qualified nearly 30 years ago. It has stayed exactly the same because it works particularly well with very few problems. So why change it, I think, is the ethos behind this. And basically, options for feeding. So there's two main types of feeding that you might hear us speak about: pump feeding and bolus feeding. Pump feeding, as it sounds, being connected up to a feeding pump, kind of like a drip, but it's going into your peg tube instead of into a vein. And bolus feeding, bolus is just a posh word for meal. So it's like little mini bottles of feed given in several meal type feeds over the course of the day, or any mixture of the two. And pump feeding, again, just to give you a little bit of insight into, because also when we come out, if you work in a care home or whatever, and somebody is thinking of having a peg placed, or you see them out in the community, I really, really value any professionals that are involved with these people, really value your opinion as to whether you feel pump or bolus feeding would be useful, because you, at that point, you know them better than I do. So pump feeding, normally we would feed for anywhere between 8 and 16 hours a day. If somebody was only pump feeding, so not eating anything by mouth, 8 hours a day, even that's pushing it slightly, is absolutely the minimum really number of hours that you would be able to get in the full amount of nutrition into somebody. Quite often 16 hours I would really try and steer clear of, because that's like all your waking hours really, and I would really try and steer clear of that. But quite often 10 to 12 hours can be the norm, but I'm still fully aware from a quality of life point of view, which is super, super important when you have a quite often a shortened life ahead of you. I would try and feed for as low a period of time as possible. It's usually one large bottle of feed that contains everything. So these feeds are designed to give you all of the calories, proteins, vitamins, minerals, everything, all in one bottle, for you to be able to survive on for the rest of your days. And I see people without neurological conditions as well. And we have people on these feeds, some of them been on my books for 15, 20 years now, and they are fit as a butcher's dog. So they really, and tend to have beautiful skin as well, and very wrinkle free. So um, can sometimes be given overnight. As time, when I first started in dietetics, nearly everybody was on a pump feed, and nearly everybody was fed overnight. Um, that's kind of become less popular really as time has gone past. And I think it's also linked in with the types of people. When I first qualified, everybody that had a peg feed had a stroke, and they were in bed all the time, and feeding them overnight was the norm. Now we have a whole cancers, neurological condition, loads and loads of different people on peg tubes. So feeding during the day is much more common than feeding overnight now. And also feeding during the day, if you're not having anything to eat, if I ran all your nutrition into you when you were asleep and then said you're not allowed to eat anything at all during the day, imagine what would have happened to your hunger levels. I don't think I could go all day without feeling hungry at all if I hadn't had anything since 8 o'clock that morning. So I think it's also overnight feeding. Lots of people think, oh yeah, it gets it all out of the way with. But it does. I always ask the question, what's going to happen with hunger? Because being absolutely permanently hungry is no quality of life as far as I would be concerned. You can use a backpack in order to be mobile. So again, lots of people think you have to be connected up to the power. These pumps can run for 24 hours without being plugged into the power. So they do a backpack system that you can load the pump and the bottle of feed and everything into, and somebody can just hike it over their shoulder or over the back of a wheelchair and go off out and about for the day. You don't need to be connected into the power. Bolus feeding is more like small meals of feed. And normally the little bottles, it's the little Ensure bottles, which were never actually designed for tube feeding. They were designed to be drunk orally. But as the years have gone past, they're the bottles that we tend to use, because you open them, you use the full bottle and you throw it away, which is much more hygienic than opening up the big bottles and closing them, and then you have to put them back in the fridge and so on. So it's a lot more kind of user friendly. But most of those little bottles are designed to give you all the nutrition you need in 5 bottles per day. You can get away with 4, with occasionally with 1 or 2 of them, but most of them are 5 times a day. No pump is needed, obviously. Handy if going out and about, because all you need is actually, the bottles don't need to be refrigerated once they're sealed. They're like long life milk. So you can just pop it into your handbag and pop a clean syringe into your handbag with a little bottle of water to do some flushes, and you can go off out and about and actually feed. It takes about 20 minutes to give 1 bottle of feed. So if you're given peg feeds in care homes or in people's own homes, please don't fire it in 5 or 10 minutes. It will most likely cause them to feel nauseous and most likely cause it to be loose out the other end. So lots of people say, and I hear it from lots of health professionals as well, oh yeah, everybody on a peg feed gets diarrhea. No, they don't. Absolutely not. And not on my watch. 100% they don't. Normally, it's to do with giving the feeds too quickly. And when we say slowly, it is painfully slowly. If you are doing it by hand, those bottles tend to be 200 mils. Some of them are only 125 mils. 200 mils. The syringe is 60 mils. So you're looking about 3.5 syringes. So you're looking at, for one syringe of feed, about 5 minutes. That is painfully slow to put in, but that's the speed it needs to be put in at. But it can be, I feel, time consuming in a hands on kind of a way. So with the lots of people just, oh God, no, I don't want to be connected up to a pump. They just think that's the worst. But actually, you start your pump off first thing in the morning, if it's in your backpack or whatever, you just go about your day. You don't actually have to think about it at all. It just runs away in the background all day without you having to do anything to it. If you're doing 5 feeds a day, if you're out of bed for 15 hours, that's a feed every 3 hours. It can be quite disruptive depending on how mobile people are and how much they're getting out and about. And not everybody feels comfortable doing feeds when they're out and about. Some people would not dream of it. They wouldn't even show their peg tube to their family members, not mind sit in a restaurant and do a peg feed. So it's not always, although we do have far more people on bolus feeds now than pump feeds. Potential benefits of peg placement. So it does free up time to do other things. Like I was saying before, people can spend hours and hours and hours trying to eat each day. Quite often, and I always ask people, and I'll never stop asking people because it's kind of learning. Quite often, particularly with people with MND, they put off having a peg tube quite often for as long as they can. And once they do have it and they start feeding, quite often I'll leave it 3 or 4 months and I'll say, looking back now, what would you have done? Would you have done anything differently? And quite often I would say, not all the time, but the majority of the time, people will say, actually, I would have had it done a little bit earlier. It's really taken the pressure off. I wasn't really able to drink enough and I was constipated. Now I can put fluid through my tube. I can put all my medicines through the tube, and some of them tasted rank and others I was struggling to swallow. And now I can actually eat a smaller amount and actually enjoy it with the family, and we can give top ups of the feed through the tube. So quite often, from a quality of life point of view, quite often they describe it as, oh, I think this is the beginning of the end, having the peg tube placed. Quite often, a few months down the line, it's actually been of huge benefit to them. So you can give all your nutritional needs, and that sometimes can help with energy levels and giving you the energy that you need to lead the life that you want to lead. Weight gain and improved nutritional status can obviously, from getting the correct nutrition, can be a benefit. It can help to prevent pressure areas as well, because obviously poor pressure care along with poor nutrition can contribute to pressure areas. Or if you have developed a pressure area, having really poor nutrition means they take months and months and months to heal. So you need good nutrition to heal pressure areas. Improved hydration can obviously improve constipation, like we've spoken about. Um, what I will say is, just to point out to you, lots of people think, and lots of health professionals think, if you have a peg placed, you won't ever aspirate again, and that's rubbish. It reduces the risk of aspiration. It does not eliminate it. People can still, and obviously, again, you have to swallow your own saliva. It might not be feed that you're aspirating on. It could be aspirating on your own saliva. So, but quite often you can see a reduction in chest infections, but it doesn't necessarily get rid of them completely. And you can give all your meds through a peg, which is increasingly difficult for people with swallowing problems. And unlike you would think, it's not the big tablets that people actually have issues swallowing, it's the little tiny little ones. The smaller they are, the worse they are to swallow, quite often people tell me. It can decrease work from a carer perspective or a family perspective as well. Preparing a pureed diet is no fun, believe me. When the pureed diet needs to be 100% lump free, trying to get that 3 meals a day or sometimes 3 snacks a day it's an awful lot of work for people. There are commercial companies, places like Wiltshire Farm Foods or Oak House Foods where you can buy in pureed meals, but they're expensive. So unless you have a few quid in the bank, it's not available to every family. So preparing a pureed diet is hard work, and also time for feeding. If you have somebody with no arm movement or severe arm movements that can't feed themselves, you have somebody having to take time out of their day 3, 4, 5, 6 times a day to help somebody to feed. So it can be a round the clock feat. And decrease stress for the patient. And also for carers. So being fed, I don't know if anyone here has ever been fed by anybody else, apart from in the romantic sense, it's not a pleasant experience. I remember doing this on a speech and language therapy course years and years ago when I first qualified. And I remember thinking, oh, this is just every sort of wrong. It's sitting there waiting and not knowing, do I open my mouth too quick? Have I not opened it quick enough? And from the carer's point of view, not knowing, have they swallowed it? Or I always remember my husband one time went in and had to have a procedure, and he had Venflons in all over his arms. And I remember he said, I'm absolutely starving when it was all done, and he had to wait in the ward for a few hours. And I remember he was starving, so I went and got him a sandwich and a drink and all the rest of it. And he tried to take the drink, and he went, oh, he said, that's hurting because it was in the bend of his arm. I said, here, I said, give it to me. I said, I'll do it for you. And yeah, I held it up, and it was only when I'd done it, I kind of thought, we didn't agree any sign as to when his mouth was full. So I just kept the cup there. And he was like, you could see the panic rising in his face, thinking, my mouth is full, my mouth, stop pouring. And in the end, we had to agree. I said, lift your eyebrows. I said, when you want me to take it away. So there we were on the ward, me going like that and him going. It's not a pleasant experience being fed, and it's time consuming, and it's, I don't know, when it's your other half, you don't want somebody to feel like your carer, do you? So it can be really stressful, and having a peg place can take away some of that stress. Potential risks. During the placement, you can have things like perforation, you can have bleeding, in really unfortunate, and it doesn't happen very often, thankfully. You can have a tear in the esophagus or in the stomach from the endoscope being put down. The more common ones, I would say, the risks for peg placement are actually following the peg placement. So things, you can have abdominal pain for a few days afterwards. If you're really unlucky, and again, it's something we very rarely see, but you can get like peritonitis, which is inflammation of the lining of the abdomen. You can get infection around the tube site, and that's, I wouldn't say common, but it happens not to everybody, but often enough in what I see. Blockage of the tube, if you're flushing a tube properly, you shouldn't be getting blockage of a tube. It's as simple as that. And leakage around the site sometimes can be an issue. And just finally, a few important points to note. Timing, so this is all to do with peg placement. Timing of placement, the earlier the better, really is the message on that score. Having the conversation about a peg is not decisive. A patient can still decide against it. So I think sometimes people kind of feel if they're going to be referred to gastroenterology, it's kind of them starting the process. And I always stress to people, you can go and have the conversation and you can still turn around and go, thanks very much, but no thanks. So it's not once you have the conversation, that's it, it's automatically leading to a peg. It is only a conversation. Care won't be withdrawn if a patient says no to a peg. I do think sometimes, and I go to great effort to make sure they don't feel like they're letting anybody down by saying no. It's a hugely personal decision as to whether to have a peg or not, and there's no right or wrong. And lots of people feel that they will be kind of letting you down or afraid to say they don't want one. Absolutely fine to say they don't want one. It can be placed and not used for months or years. Patients can eat and drink orally with the peg in place. You can have a peg feed running and be eating and drinking at the same time. It's not one or the other, and it's really important that people are aware of that. A best interest MDT decision is required for those that don't have capacity. So obviously we would want all the relevant health professionals involved. peg placement won't halt disease progression. So with any of these conditions, just being better nourished will not keep you alive for longer. Your disease will still progress. And as a dietitian, I think it's really important that people are aware. I'm neither for or against peg feeding. I think loads of people feel as a dietitian, I'm going to be, I'm thinking to get good nutrition in, and therefore I'm going to push people to have a peg. And I often do say it, and they kind of look at me, and I go, I couldn't give two hoots whether you have a peg placed or not. I will go home and I will sleep well tonight. All I want to do is make sure that people have all the information that they need to make a good decision for themselves. Some people ethically just go, no, it's kind of artificial and I don't agree with that. It's not God's will. Other people will turn around and go, I actually am suffering and I don't want to extend that suffering at all. So no, I don't want to have a peg placed. And just for people to be aware that they will still get the full support of the NDT no matter which decision they make. And that is me done. Does anybody have a question?
Just regarding the bonus feed, you said it's about 200 mil, maybe like 25 minutes, or 45 hours. Why is that?
Basically, the simple way of explaining it is all of the fluids in your body are at a certain concentration. The feeds are highly concentrated, so I'm oversimplifying it now. When you put it into your gut, your body goes into a bit of a panic and goes, oh, hang on a second, this is way too concentrated and I'm not comfortable with this at all. So what it does is it floods water into your gut from your surrounding tissues to dilute down the feed down to a nice concentration. You then have, I'm a bit of a straight speaker, I apologise, this big watery ensure mixture work its way down through your gut, and quite often there's not enough time for the water to be reabsorbed, so you get a right big watery poo out the other end.
So it's not necessarily about the actual mechanism of it going in, it's the
yeah. If you drink these supplements and down them in 5 minutes, it will have exactly the same effect. Yeah. Some people do say, actually, I was quite constipated. That's worked quite well.
Thank you very much for your time. So, when you were talking about people having difficulty with feeding, and you said something about, I just want to find out if there is any equipment. So, from OT point of view, we want to always make sure that people are independent. So, even though they have this diagnosis, some of them might still want to experience being able to feed themselves. So, in your practice, do you have specific equipment that can help them, support them with feeding, and to the referrals to?
So normally, although I'm aware of what's available, normally that comes within the remit of the occupational therapist. But there are loads of things available. I suppose to touch on a few, everything from heated plates to keep your food warm, because obviously it's taken you half an hour to so that your food doesn't go cold. There's plates with kind of lipped edges that come up and over the top, so that say if you're trying to feed yourself single-handedly, you can scoop it. Obviously with a normal plate it would just fall off the side of the plate. You can scoop it, but as the spoon goes near the lip forces the food over and it falls onto the spoon, so that you're able to single-handedly get food on.
The automated ones, I know those basic ones. The automated one that can sit and have their food.
Like a machine to feed them?
Yes.
No.
There's something called a meter return.
Mobile apps try that one.
So that would be, they would be the things we try to come across.
And what's your waiting time?
For our services, it's 2 weeks for an urgent and 6 weeks for a routine.
And any professional can refer? Because sometimes they'll
Yes. No, any professional can refer to dietetics.
Thank you.
Yes, so if there's, in order to get a peg placed, you have to have the camera down. So if there's any reason why the camera can't go down from a physical point of view, if you had strictures or whatever, you can't have a peg placed. With an awful lot of the conditions that we come across, particularly with the likes of MND, you have to be able to lie flat to have a peg placed. And when people lie flat, their oxygen saturations fall, and the procedure becomes obviously much more dangerous for them to have. So quite often, if you can't have the scope down for any reason, that's when they would do a rig. Or sometimes we see sometimes, don't we, where they've gone to place a peg and actually all their anatomy is kind of slightly off kilter and the stomach is up behind the ribs and they're not able to get the peg in. So it can be a kind of physical anatomy thing sometimes as well.
And with the sort of diaphragmatic weakness, that's more of a problem. So I think we've seen more rigs recently than we have done previously.
Just a question about if you think someone's peg is blocked or not working properly, and so if I've gone to see someone into a care home or at home in the community, usually I just sort of like send them into hospital. But I know it's the right thing to do, but my question is there anyone I should be contacting before they go into hospital to say like, oh, I think this peg is blocked, or do we just have to go into A&E and just?
I would say it's a rare occasion when somebody should have to go to A&E for a blocked tube. And it's something that anybody, you don't need to be a health professional to do it. And basically what we would say is please don't use Coke and stuff like that. That's a real old-fashioned thing to do, where they kind of go, oh, it cleans a penny, so it'll unblock anything. It's quite an old-fashioned thing. What we would normally suggest that you do is fill a syringe about halfway with warm enough to be able to hold your finger in it, not hot, warm water, so about halfway, connect the syringe onto your blocked feeding tube, and rather than trying to push down, because when the feeding tube is blocked, you could put your whole body weight behind it and you won't be able to push it down, but rather than do that is actually to pull back on it and let go, pull back and let go, pull back and let go, and bit by bit what you'll start to see is little bits start to break off the blockage, and eventually, and it can take time, and I'm talking half an hour plus sometimes, eventually at some point you'll pull back and it'll fly back at you where the blockage has gone, and then we would recommend that you give really good several flushes of water.
Okay, because I'm a tissue viability nurse, I haven't done peg feeding since I was a student, so I personally probably wouldn't be able to do that at that time. So, but
you could advise a family member to do it. Yeah. And normally they get trained quite often as well when they get the peg placed about how to unblock a tube. Okay. Whether they remember it 5 years down the line is quite another thing, isn't it?
Yeah. Okay. Thank you.
Good. Oh, sorry.
What's the implication of that using Coke to flush? What's the implication?
Basically, if it depends what the blockage is made up of. If the sugar in the Coke can basically stick to the blockage and make the blockage even bigger. So it's why I think it was Coke that came around is what can help is the bubbles. So basically, or if you have a feeding tube that's all kind of built up with residue on the inside, what can help is like either just cheap fizzy water from the supermarket, or fizzy tonic water or soda water. But it's the fizziness that's the thing. As the bubbles fizz down the tube, they help to clean the inside of the tube. So I think that's where the Coke came from, was because it was a fizzy drink. And this would have been long before even I qualified, so it was before fizzy water became a thing. Yeah. Good, I'm aware of time, so eating into your break.